Okay, thank you everyone for joining in. Today it's my pleasure to introduce Dr. Roni Bitterman. She is a Transplant ID Fellow. She is from Israel, where she has done some work on MDR gram-negative bacteria, as well as other studies. So today her talk is Bad Bugs and No Drugs, the case of MDR gram-negative bacteria, which we are unfortunately becoming quite familiar of. So Roni, without further ado.
Thank you. Wait, it's not responding. Okay, so I have nothing to declare. We're going to start with an introduction to MDR gram-negatives, then have a case on ESBL enterobacterialis. That's the new name for enterobacteriaceae, but I'll probably still call them enterobacteriaceae during the talk. The second case will be about CREs, carbapenem-resistant enterobacterialis, and the last one would be about MDR Pseudomonas, and then we'll summarize. So this data is from the WHO. They estimate that the annual mortality from antimicrobial resistance is around 700,000 cases per year today. And you can see how it compares to other causes. For example, car accidents, only 1.2 million. So they also predict that by the year 2050, we'll have 10 million deaths related to antimicrobial resistance every year. So it's getting to be a very big problem. The WHO also classified the pathogens that we have today, the drug-resistant pathogens, to those that are of critical priority, high priority, and medium priority. And by that, they mean to which bacteria we should drive the creation and development of new antimicrobials. And their critical priority pathogens are all gram-negatives, being carbapenem-resistant Acinetobacter baumannii, carbapenem-resistant Pseudomonas, and both carbapenem-resistant and ESBL-producing Enterobacterialis. And the problem is that we don't really have any new drugs. The first antimicrobial was developed in 1928. And since the 1990s, we don't really have any new drugs. So it's not that we have nothing, but all the new drugs are actually modifications of previous classes, and we don't really have any new classes developed. This table, you don't need to read it. It's just to get a feeling of the thing. It's the antibiotic pipeline as published by the WHO. The WHO actually created this innovation criteria for developing antimicrobial. And an antimicrobial will be classified as innovative if it has a new chemical structure, if it has no cross-resistance with other antibiotics, if it targets something new, or it has a new mode of action. And you can see the very few V signs that you have on the table. And also they're classified the new antibiotics, and again, not responding. Here. To whether or not they answer their critical priority pathogens. And you can see by the full dots, the black dots, how few critical pathogens are covered by the new antibiotics. Just really quickly about resistance mechanisms, because when you talk about MDR bacteria, it's hard not to talk a bit about resistance mechanism. So the most important mechanism for gram-negatives is the drug modification destruction. And for beta-lactams, it's the beta-lactamases. And they have this hierarchy to them. We have the narrow spectrum beta-lactamases. These are the enzymes that destroy drugs like penicillin, cefazolin, and etc. Then you have the ESBL, the extended spectrum. These enzymes, third generation cephalosporins like ceftriaxone and ceftazidime. And then we have the carbapenemases like APC, NDM. We'll talk about that a bit more. And they destroy practically all beta-lactams. Another mechanism is the efflux pump. That's a pump that takes the antibiotic from the bacteria and takes it outside. And we also have porine mutations. Porines are channels that let the antibiotic in. So when they're mutated, the antibiotic can't get in. And the fourth mechanism, which is target modification, is less important for gram negatives. For Enterobacteriaceae, the most important thing is the beta lactamases. But when we're talking about Pseudomonas, the efflux mutation, the permutations are important as well. I just wanted to say before we get into the cases, a word about the local susceptibilities. So this is data from here, from 2018 to 2019, from MOT only. And first we're looking at the Enterobacterialis, the E. coli and Klebsiella. And you can see you have a blood source and a urine source. So for meropenem susceptibility, we're in a very good place. E. coli is 100% susceptible. Klebsiella in urine does have carbapenem resistance at a rate that's not negligible. And what's more concerning, I think, is the ceftriaxone resistant, which is a surrogate marker for ESBL. So you can call this ESBL, and the rate of ESBLs among E. coli and Klebsiella are very high here, with only 40 to 55% of susceptibility to ceftriaxone. And when we look at Pseudomonas, and this is for respiratory samples, Pseudomonas is a bacteria that can be practically any antibiotic. It doesn't follow the hierarchy that we see with Enterobacterialis, that meaning if the E. coli, for example, is susceptible to cefazolin, it will necessarily be susceptible to ceftriaxone and meropenem. And if it's susceptible to ceftriaxone, it will be susceptible to meropenem. But Pseudomonas is not like that. It can be susceptible to meropenem, but resistant to ceftazidime and the other way around. And you can see that the situation in 2019 was better than 2018, where 3/4 of the Pseudomonas were susceptible to meropenem, piptazo, and ceftazidime, but only half were susceptible to ciprofloxacin. And we're moving to our first case, which is ESBL Enterobacterialis. So this was an 80-year-old female. She had a kidney transplant in 2014 for chronic glomerulonephritis, and she has recurrent UTI, which is a common problem. She was on Keflex, which is cephalexin prophylaxis, but previously she was on fosfomycin because of diarrhea. And her urine isolates were intermittently pan-sensitive Klebsiella and ESBL Klebsiella. And she was admitted just in February because of a fever of up to 40 degrees in the past 4 days, and was started empirically on meropenem. And these are her blood and urine cultures. So you can see in the blood culture that Klebsiella pneumonia grew, and it's ceftriaxone resistant and meropenem susceptible. And the same susceptibility profile was seen in the urine with the same drug, meaning that this patient has ESBL producing Klebsiella pneumonia urosepsis. So we're going to talk a bit about that now. The issue of giving beta lactamase inhibitors, which for example is amoxiclav, piptazo, compared to meropenem started, I think, in 2004 with the first publication by David Patterson, which is an Australian doctor, that suggested that it may be that carbapenems are superior for ESBL Klebsiella. And following that, there were many retrospective cohorts that studied this question, some showing that meropenem are better, I think mainly North American studies, and some showing that they're as good as beta-lactamase inhibitors. And in 2018, we got the very long-awaited Merino trial. The Merino trial was a randomized controlled trial that compared piptazo to meropenem for E. coli and Klebsiella that are presumably ESBL producers. And you can see they're very remarkable, which I think surprised the Merino investigators as well, difference in favor of meropenem with 12% mortality in the piptazo arm and almost 4% in the meropenem arm. And meaning that in this study, at least piptazo was not non-inferior to meropenem. And you can see this weird confidence interval with the endless one side. I think the reviewers of the Merino trial made them do this because it was a one-sided trial. But you can take the results of the Merino and recalculate them and put them in a two-sided confidence interval. So this is the reported Merino trials with an endless one-sided confidence interval. And here you have the recalculated Merino results. So you can see that the confidence interval was between 3 and 14%, meaning that we cannot exclude completely non-inferiority because some of the confidence interval is below the 5% non-inferiority margin. But generally, it does seem from here that meropenem is superior, as all of the confidence interval is to the right of the zero line. The Merino investigators then published this post hoc analysis of their trial. They took 320 out of the original 380 blood culture isolates, and what they looked at was broth microdilution evaluation of the piptazo-MIC. What does that mean? Broth microdilution is the gold standard for determining susceptibility to antibiotics, but it's labor intensive and it's done in research only, and it's not relevant for a laboratory that serves a hospital. But for, of course, this trial, they did this. And what they saw is when they check for meropenem susceptibility, everything is fine. The automated methods they used in practice in the hospital laboratories matched the broth microdilution completely, and all the isolates were really susceptible to meropenem. But that wasn't the situation with piptazo. You can see here the distribution. This is the breakpoint for piptazo susceptibility, and you can see that quite a few isolates were to the right of this line, meaning that according to broth microdilution, they were resistant to piptazo. And also a significant number of isolates had a piptazo-MIC of 16. So 16 is thought to be susceptible, but it's a problematic MIC. And according to UCAST, which is the European organization that determines breakpoints as compared to the CLSI, which is American. So they call the MIC of 16 ATU, meaning area of technical uncertainty, which means we don't really know what to do with this MIC, and we're not sure that it should be classified as susceptible. And then they took the results of susceptibility according to broth microdilution and recalculated the Merino results. So here on the top, you can see the original results of the Merino trial with a 9% risk difference in favor of meropenem, all the confidence interval to the right of zero line. But when you take, and here you see only the susceptible strains according to the broth microdilution, and you exclude the isolates with a piptazo-MIC of 16, the results are much less significant now with a risk difference of only 4%, and it crosses the zero line. So what I think we can say is maybe meropenem is superior to piptazo, but maybe the problem is actually that we don't know how to determine piptazo susceptibility and not that it's really an inferior drug. After the Merino trial, I think it caused a big buzz in the ID world, and the JAMA that published the paper got many letters in response to the trial. These are the two that were published, and the different investigators around the world have different comments on the Merino trial, being that the mortality was all related almost to malignancy and not to infection, and the fact that the UTI cases were unbalanced, and many, many more. I personally think that the problem was the calculation of the sample size. But anyhow, I think this justifies another trial to confirm the results or confirm the opposite. And there's actually another trial that is currently ongoing in several sites around the world, and it's called Bitterman, and it's basically a replication of the Merino. So what can we take home from the ESBL case? So current data is in favor of carbapenem over combination of beta-lactam, beta-lactamase inhibitor, but I do think there's room for another RCT to confirm this result. And I think if anything, we learned from the COVID situation is that not every randomized trial is the same as the other, and there's always room for replication. We're moving to the second case, the CRE, the carbapenem-resistant Enterobacterales. So we'll start with some terminology. So I hope you know what I'm talking about later on. So carbapenem-resistant Enterobacterales can be classified to either carbapenemase producing or non-carbapenemase producing. And this is based on either phenotypic tests which are hydrolyzation of carbapenems tests, or genotypic tests where we identify the enzyme by PCR. Those that are carbapenemase producing are further classified by the class of carbapenemase. That's according to the genotypic test. And then we have either class A, which is the KPC, class B, which is the metallobeta-lactamases like NDM, VIM, etc. And then we have the oxacillinases, which is class D, like the most important one is OXO48. So we're going to our case. This patient was a 52-year-old male. He underwent living donor liver transplant for cryptogenic cirrhosis in October 14. And a week later developed abnormal liver enzymes, hepatic artery thrombosis, and was relisted for transplant. 2 days later, we were called for consult because of fever up to 39.4. On examination, he seemed to have abdominal tenderness on palpation. He had leukocytosis, his creatinine was okay, and he grew gram negatives in blood cultures taken both from his CBC and peripheral blood. And the urine culture was pending. And at that time, we already knew that on the screening swab that was taken on admission, he was found to be a carrier of carbapenemase producing Klebsiella pneumonia, and that the enzyme was OXO48 being the class D carbapenemases. And when we saw him, he was on piptazo and fluconazole. So according to our judgment and in light of his CPE carriage, we changed his antibiotic treatment to meropenem, colistin, and micafungin. 2 days later, he underwent the redo liver transplant. At that point, we already knew that the blood culture isolate was indeed the Klebsiella pneumonia that was OXO48 positive. And in the OR, they saw large bullous abscess that they drained, and they saw that the previous hepaticojejunostomy was leaking, and the OR cultures grew the same Klebsiella pneumonia. 2 days later, we got the full susceptibility for the Klebsiella, and you can see how it's resistant to almost all drug classes we have today. And they also tested for ceftazidime avibactam, which we will talk about soon, and it was susceptible. They also tested tigecycline and fosfomycin, and both were marginally susceptible. And for colistin, which was interpreted as intermediate, but actually has low MIC, and we'll talk about that also. We tried to find ceftazidime avibactam, like I said, it was susceptible, but we couldn't find any available. And we changed his treatment to colistin, tigecycline, and IV fosfomycin. But blood cultures continued to be positive. So we did an abdominal CT and found a collection of perihepatic fluid. So we underwent debridement in the OR, where they found significant amount of turbid and purulent fluid, subphrenic space. And after this debridement, his blood cultures ceased to be positive. So we'll start about CRE in solid organ. Solid organ patients are at increased risk for MDR gram negatives, including CRE. That's because they're frequently hospitalized, they're hospitalized for long durations, they receive antibiotics and that are often broad spectrum, and they have different manipulations done, and they carry different devices like urinary catheters and CVCs. The rate of CRE infection varies according to the geography and the transplanted organ, but in some areas, in the endemic areas, it can reach 10%, which is of course not the situation here. The risk is highest in liver transplant, where it can manifest as either bloodstream infection, intra-abdominal infection, or surgical site infection. And in our patients, it was all of it together. And infection site usually correlates with a transplanted organ. Infections carry a high mortality rate in general, and in the SOT population, it can reach 50%. Both AST and IDSA published guidelines on how to deal with MDR gram negatives, and we're not going to deal with it a lot. We're going to talk about the evidence behind them, but just to say that the AST recommend using new beta lactams, which we'll talk about, and as an alternative, they recommend combination of either carbapenem, polymyxin, which is colistin here, and tigecycline. The IDSA, along the same line, more or less, recommend the new beta lactams as first line. And a second line, they don't recommend combination. They either recommend cefiderocol, which we'll talk about and understand why it's only second line, or the tigecycline. So what antibiotics do we have against CRE? So first, we have the old antibiotics. These antibiotics resurrected thanks or due to the CRE. They have a susceptibility rate of approximately 50 to 80%. The next antibiotics are the tigecycline or the newer formulation eravacycline. Tigecycline has a susceptibility rate of approximately 85%, and eravacycline is probably better. The problem is that tigecycline has a black box warning from the FDA because trials mainly in pneumonia showed increased mortality with tigecycline. But some may argue that the problem was not the drug itself, but that it was underdosed in these trials. Next, we have plasomycin, which is a new aminoglycoside. And if all the aminoglycosides have a coverage rate of approximately 50% for CREs, then this new aminoglycoside has almost 100%. And last, we have the new beta-lactams. They are usually a combination of beta-lactam and beta-lactamase inhibitor. And the problem with them is that they are very, I would call them niche antibiotics. Each antibiotic is good for a specific enzyme, a specific carbapenemase. So we have meropenem varbobactam and imipenem relebactam, both, to my knowledge, not available yet in Canada, and they're only good for the KPCs, the class A's. Then we have ceftazidime avibactam, which is good for KPC and some of the oxas. Cefiderocol, supposed to be the wonder drug, the golden bullet against MDR infections, and we'll talk about that soon. And last one is still investigational, not yet FDA approved. It's Aztreonam avibactam. And it's special because it is supposed to cover the class B, the metallobeta-lactamases. But since we don't have it yet available, what people do is they take ceftazidime avibactam for the avibactam, and they take just Aztreonam, which has been available for many years, and they give them together. And then you get this sort of Aztreonam avibactam. We'll start with the old antibiotics, which, like I said, were resurrected thanks to carbapenem resistant gram-negatives. So why don't we like polymyxins? First of all, when you compare them in retrospective studies to beta-lactams, they're inferior. They have an unfavorable side effect profile, mainly nephrotoxicity and neurotoxicity. We don't really know how to test for susceptibility, and we'll talk about that too. We don't really know how to dose polymyxins, and they have a limited range of coverage. They don't cover Proteus, Morganella, Providencia, and Serratia. How should we dose polymyxin? So like I said, we don't really know. First of all, the terminology is confusing. Some places dose according to CBA, dose according to CMS, CBA being colistin base activity, CMS stemetat sodium. Some places use milligrams, some use international units, so very confusing. In general, our target should be concentration in steady state of 2 milligrams per liter. But the problem is that even this concentration is probably underdosing for pneumonia, but higher concentrations are associated with nephrotoxicity. And when you take a patient which has a normal EGFR, then the probability of attaining this steady state concentration is pretty low. It's only 40%. So we have a problem with the dosing. In general, we should always use a 300 milligram loading dose. And here you have the table for adjusting the dose according to the creatinine clearance. And like I said, the second problem is determining susceptibilities. So like every other antibiotic, broth microdilution is the gold standard. But the problem with colistin is that all other methods have unacceptably high error rates. And if you remember, when we looked at the susceptibility profile for our patient, they said for colistin, although the intermediate, and that's because the methods for determining susceptibilities are unreliable. And another problem, which is that for other antibiotics, we determine susceptibility and determine the cutoffs according to clinical breakpoints. So it's based on clinical data. And for colistin, it's based mainly on the epidemiological cutoffs, which is the wild type distribution of the bacteria. Next, we'll talk about fosfomycin. So this trial was a randomized controlled trial that compared piptazo to IV fosfomycin, not the oral fosfomycin that we use for cystitis. And there weren't many MDR gram-negative. There were about 25% ESBL and very few CREs. But I think this is mainly a trial that shows a proof of concept that IV fosfomycin is actually a drug that can be used for serious infection, complicated infection, and not cystitis like the oral formulation. So here, the primary outcome was overall success, combination of clinical and microbiological cure. And you can see that it was 55% in the piptazo arm, 65% in the fosfomycin arm, meeting the non-inferiority outcome and actually maybe being in favor of fosfomycin. Now we're moving on to the new beta-lactam. So we'll start with ceftazidime avibactam. And what you'll see with the trials that I'm going to talk about from now is the problem that we have with all new antibiotics. So we generate new antibiotics mainly for the MDR organisms, for the resistant organism. But practically, they are tested only on, I won't call it simple, but infections caused by drug-susceptible bacteria. That's because of the FDA demands. So we have very few data on randomized control trial data on these antibiotics in patients who have MDR gram-negatives, which is what I'll try to show now. So for ceftazidime avibactam, it was tested in a randomized controlled trial of over 300 patients, but these were mainly ESBL gram-negatives and not really CRE. And it was compared to best available therapy, which, because it was mainly ESBL, was carbapenem, and it was mostly UTI. And you can see here in the panel above, that's the clinical cure rate, which was the primary outcome, and how it's similar between ceftazidime avibactam in red and best available therapy in blue. And this same picture was seen when you looked only at the microbiological response. But again, these are mainly ESBL patients. And when you try and look at CRE patients in ceftazidime avibactam, then there's only retrospective studies or observational studies, more correct. This cohort was actually prospectively collected, but only observational from the US for CRE infections. They compared 38 patients who were treated with ceftazidime avibactam with almost 100 treated with colistin. And the infections were mainly bloodstream infections and pneumonia. And you can see what seems to be the very high mortality rate with colistin compared to the ceftazidime. And this was actually statistically significant even after adjustment, with a 23% risk difference in favor of ceftazidime avibactam. But as with every antibiotic, the problem is resistance. And in this cohort of 37 patients with CRE infections who were treated with ceftazidime avibactam, 10 had microbiological failure. And out of these 10, 3 developed ceftazidime resistance under treatment. And this is another case report. It's a liver transplant who developed shortly after transplant bacteremia with a gram-negative that was ceftazidime avibactam susceptible. So we would treat with ceftazidime avibactam for 17 days. And then after under treatment, developed a ceftazidime avibactam resistant isolate. Meropen and varvobactam, I'll only talk about briefly since it's not available yet in Canada, was evaluated in a small RCT for CRE infections. Eventually, only 47 patients actually had confirmed CRE, and the most common infection was UTI. And you can see that the results suggest that maybe meropen and varvobactam is better than the best available therapy, which was colistin, tigecycline, or ceftazidime avibactam, comparing 66% clinical cure to 33%. And also mortality seemed to be lower with the meropen and varvobactam. Cefiderocol, although is not available in Canada yet, to talk about because it's an interesting drug, This, like I said previously, was supposed to be our golden bullet against MDR gram negatives. And it's called Fitroja because it acts like a Trojan horse. It gains access into, it's a Sidera-4, it's a phallosporin, so it gains access into the bacteria cell through the iron transporter that the bacteria uses for transporting iron. So if the bacteria has purine mutations, that doesn't matter for cefiderocol because that's not how it gains entrance. It's also resistant to all classes of beta lactamases and resistant to efflux mutations, meaning this is a drug that's that is good for all MDRs that we have today. CRE, Pseudomonas, carbapenem-resistant, Acinetobacter baumannii, which is not a problem here, but in other areas of the world is a very big problem. So it was supposed to be the answer to everything. And it was evaluated in a randomized controlled trial, even relatively large, for carbapenem gram negatives. The most common bacteria was Acinetobacter baumannii, but it also included carbapenem-resistant Enterobacterales and Pseudomonas. The most common infections were pneumonia and bloodstream infections, so serious infections. And eventually 118 patients had confirmed carbapenem-resistant gram-negative infections and were included in the trial. And this is the primary outcome, which was a combination of clinical cure and microbiological eradication. And it was similar to best available treatment, which was like colistin, which was mainly colistin, sorry. So seemed very promising. But this is what happened when they analyzed the mortality data. And you can see that while mortality was similar in the UTI group, which was the minority, in both pneumonia and bloodstream infection, mortality was significantly higher in the cefiderocol group. And it was higher when they analyzed the different time points. And they got this adjudication committee that was supposed to decide each mortality case, why it happened. And actually they couldn't find common cause. There was an increase in both gram-negative sepsis-related mortality and mortality not related to gram-negative sepsis. So this is the problem that we have now with cefiderocol, which was supposed to provide our blanket solution for MDRs. And this is why, like I showed you in the IDSA guidance, that they put this as only a second line and not as a first line drug. Plazomicin is a glycoside, like we said, and also not available in Canada yet. Evaluated in a small RCT of only 39 patients with CRE infections and was compared to colistin combined with either meropenem or chitocycline. And you can see here that the mortality rate with colistin was higher than plazomicin. And also, although both drugs are nephrotoxic, nephrotoxicity related to colistin was higher than that of plazomicin. So this also seems to be a promising drug. And the last topic I wanted to talk about regarding CRE is whether or not should we treat with combination therapy. So why should we treat with combination? There are in vitro studies saying that when you combine polymyxin, colistin, with carbapenems, there is synergism in vitro. And there's also some data that there is less development of resistance. Later, there were retrospective studies, and this was the most important one, from 5 centers in Italy and 660 episodes of KPC producing Klebsiella pneumonia infections. And this was the main study that suggested that maybe if you combine colistin with meropenem, you get better results. So you can see here, only in the group that had a meropenem MIC of 8 or lower, that the mortality was significantly lower when combined with meropenem than when given as monotherapy. There were also some meta-analysis that also eventually suggested that there maybe is a benefit to combining treatment for CREs. And this is what led to this RCT that was published in 2018. It's called the AIDA trial. It compared colistin with colistin meropenem combination, and it was for carbapenem-resistant gram-negatives. The most common bacteria here was Acinetobacter baumannii, but that's because of the countries that it was done in. And you could see that the primary outcome, which was clinical failure, was similar between the two groups. And here you see a figure of the mortality rate. And again, it's similar between the two groups. You could, of course, argue that this was mainly an Acinetobacter baumannii trial and not many CRE patients, only 73 CRE patients. And maybe where the jury is not out about combination versus monotherapy for CRE. And there is actually another RCT that just finished recruitment. It's called the Overcome study. And we're awaiting the results later this year. And maybe this trial will have more CRE patients and will provide an answer for that as well. So my take-home messages for CRE is that we do have new drugs, but each drug has a specific mechanism, is good against a specific mechanism of resistance. So it doesn't really provide a blanket solution. And it does seem that the newer drugs are better than the resurrected old drugs, mainly being colistin, and that our current data does not support using combination therapy for these infections. And we're on to our last case, which I promised will be shorter. So this is a 53-year-old patient, male, that had double lung transplant in September 2020 for CLAD. And his first double lung transplant was in 1991 for cystic fibrosis. He has a complicated infectious history, including Mycobacterium abscessus infection, Aspergillus fumigatus colonization, and he's of course colonized with MDR Pseudomonas. He was admitted because of respiratory decline with a decrease in FEV1 from 2.9 to 2.25 liters. And his chest X-ray showed patchy infiltrates in the right middle and right lower lobes. And he had bronchoscopy done, which showed copious purulent secretions in the right middle and lower lobes. And this is the bacteria that was isolated, his MDR Pseudomonas, which you can see is actually what we would call PDR, pan-drug resistant. I can say that previous isolates, although on this specific one it was not tested, was susceptible to ceftolozane tazobactam, which we will talk about really soon. So what antibiotics do we have against MDR Pseudomonas? We have ceftazidime avibactam, which we just talked about in the CRE connotation. The susceptibility rate is between 40 and 80%. We also have ceftolozane tazobactam, which we will talk about right now. Ceftolozane is mainly an anti-pseudomonal drug. It is resistant to most of the porine and efflux mutation that Pseudomonas has, and has a 50 to 80% susceptibility rate for MDR Pseudomonas. And the last one is imipenem relebactam, which again, although it is good for CRE patients, mainly KPC, only KPC, it also restores susceptibility to imipenem resistant Pseudomonas in up to 90% of the cases. So ceftolozane tazobactam, like I said, mainly anti-pseudomonal, is dosed at 3 grams Q8 for pneumonia, but 1.5 grams Q8 for UTI and intra-abdominal, which is what was tested in the original trials. We don't have any RCT for MDR Pseudomonas, like I said, for most of the new beta lactams, but we do have retrospective studies, which are quite good. This was a retrospective multi-center study on 200 patients with MDR Pseudomonas infections, of course, since it's Pseudomonas, mostly VAP. And it compared 100 patients who were treated with ceftolozane tazobactam to 100 patients who were treated with either colistin or an aminoglycoside. And you can see that the clinical cure rate, the adjusted clinical cure rate, was significantly higher in the ceftolozane tazobactam arm, and there was significantly less acute kidney injury with ceftolozane tazobactam compared to aminoglycoside or colistin, although mortality did not differ significantly between the two groups. And as with any anti-pseudomonal drugs, the problem is resistance, and this is no different. We have here one series of 21 patients and another of 47 patients who had MDR Pseudomonas, mostly VAP, and over 10% developed ceftolozane tazobactam resistance under treatment. And this was used mostly due to resistance that was related to de novo mutations in the original isolate and not because they acquired a nosocomial resistant strain. And our last anti-pseudomonal drug, the imipenem relebactam, not available yet in Canada also. it was assessed in a very small RCT for imipenem non-susceptible gram-negatives, but it was mostly Pseudomonas, and eventually included only 31 patients with confirmed carbapenem non-susceptible gram-negatives, and was compared to a combination of imipenem colistin. And while there was no difference in the favorable overall response rate, it did seem that there was a lower mortality rate with imipenem relebactam, 9.5%, compared to 30% with imipenem colistin. So what are my take-home messages for MDR Pseudomonas? Is that we do have promising anti-pseudomonal drugs, but they are all modifications of older compounds like we have for CRE. And that the problem is, as with anti-pseudomonal drug, is that there is development of resistance during treatment. So this is my last slide. And what I would like you to remember is that antibiotics are not strong or weak. They can be appropriate or inappropriate. They can be broad spectrum or narrow spectrum, but are not strong or weak. And the more we use the antibiotics, the more we lose them. So if we want to preserve antibiotics for our MDRs and to reduce the MDR rate in general, what we need to do is to use our antibiotics appropriately and judiciously. Thank you.
Thank you. Thank you, Roni, for a nice tour of new antibacterials and the issue of MDR and SOT. One thing that I wanted to ask while we are waiting for others to ask questions is, here you mentioned for colistin you have to dose with CBA. We use 5 milligrams per kilogram Q12. What is that equivalent to?
So he got our patient what does it equal in international units? It's a full dose. It's 4.5 times 2.
So that is appropriate.
4.5 million international units times 2.
Okay. Any other questions from the group? Dr. Austin?
Sorry, no, I don't have any questions.
And one more question. So if, like, our practice has been that if a patient is colonized with CRE, or for that matter, I don't think you discuss the multi-drug resistant gram positives like VRE, we empirically start them on the patients, start them with the organism to which they are colonized with. And you highlighted that in one of the cases where it was colonized with CRE and the patient turns out to have CRE bacteremia. Are you aware of any data that what percentage of patients who are colonized with CRE will develop bacteremia due to CRE?
Well, the data I found that in high, well, actually, how many develop actual infections? I do have, just a second, I'll stop sharing. Wait. So there was a trial that tried to check for decolonization for CRE patients, actually in solid organ. And they found no effect of decolonization, but the infection rate in general, and I don't know how much was specifically due to CRE, was 6% in both groups.
Okay.
So I would guess that, of course, not that high.
Okay. I think Dipali, you have raised your hand.
Yeah, hi. Thanks, Roni. That was an excellent presentation. I'm sorry if I missed it, but Can you comment on whether there's any information on what we should do if a patient pre-transplant is colonized with multi-drug resistant bacteria and they go for transplant? Should we be changing their perioperative prophylaxis? Is there any information on that?
Yeah, so there is no trial on CRE, but there is a trial on ESBL. It was before, it's not solid organ transplant or immune compromised, it's just patients who are colonized with ESBL and had to have abdominal surgery. And it was not randomized, it was a before-after trial. In the before phase, they were treated with cephalosporin with metronidazole, in the after phase with ertapenem. And what they found was that in the intention to treat population, there was no difference in infection rate. And they excused it by the fact that there was a high crossover rate between the groups. So in the per protocol analysis, there was slight reduction in the infection rate with the ertapenem prophylaxis. And there was a significant reduction in the rate when you analyzed only surgical site infections related to ESBL, but there was no difference in deep surgical site infections, which are more important, of course. So I guess the answer is there is no good answer.
Great, thanks.
Thank you. So Tina has a question. Do you think there is a role for fecal microbiota transplant to decolonize the patient of MDR bacteria from the gut in the pre-transplant setting?
Well, pre-transplant setting is a very specific situation. It's going a step forward. We're actually looking at that back home, in my hospital back home. We're checking whether fecal microbiota transplant is good for eradicating CRE colonization, and we still don't have answers for that. It's an ongoing trial. So the answer would be, I don't know.
But what would be your impression? I mean, you're doing a trial, so probably you are at equipoise, but what is your hunch?
My personal opinion is that it won't help, but.
Okay. Any other questions? I guess.
There was one person who asked, where's the chat? Well, if I envision any other form of treatments, I don't know. I really don't know. You saw the table of the antibiotic pipeline. The problem is that most of the drugs are just modifications of drugs we already have, nothing really new or innovative.
I guess there's always bacteriophages.
Yeah, that's what Tina suggested. Yeah.
Yeah. Great presentation. Thank you very much. And thank you everyone for joining in.
Thank you.
I will return 10 minutes of your day today. Enjoy those 10 minutes. Take care.